I'm not Richard Winslow. I'm Justin Baker, and I will be chairing the session on new models for integrating patient data into psychiatric clinical practice. Very pleased to have a number of folks joining the session today. Rich Winslow, Andrew Gerber, Zach Cordner, and Michelle Patriquin. So I will just hand it over to Rich for the first presentation.
Hello, everybody. It is the afternoon. Hope everybody had a very good lunch. I'll try to project and keep everybody awake. But I will be talking about digital phenotyping tools for tech-enabled clinical care. My name is Rich Winslow. I am CTO of Tetricus Labs. And as I'm meeting many of you for the first time, a little bit about who I am. I actually got a PhD in mechanical engineering, of all things. I have roughly 20 years of experience like developing and building and solving technical products and solutions for people. Actually worked at Apple for a little bit of time, so by show of hands, how many people have iPhones, had battery problems? That was totally my problem to fix. I apologize that I didn't fix it perfectly all the time, but my career path has very, very happily led me into Tetricus Labs and helping people get better faster with mental health. So I don't really want to bury the lead so much, so I want to be talking about how we are going to be building an ecosystem to help people and building an ecosystem that people actually want to use. So we think about two really core tenets that we want to use to ground ourselves in terms of building these products. The first is that data can help treatment. The second is that seeing is believing, but more importantly, seeing results is believing. So we want to at least show you so you can know what we'll be talking about of like, what is this ecosystem that we're building? So this is a result of our team's many, many weeks, days, months of effort trying to come up with what could these tools look like that we're testing actually in the field. So it's a fully integrated experience across an iOS application for patients and a web dashboard for clinicians. We're leveraging Apple Health Kit data and other wearables to gather really important information about the user activity. I'll be going through demos of how all these pieces work, and I'll save any of the other clinical analyses for Zach and others, Zach and Andrew and et cetera. But I'll focus mostly on like the product side and how we really think about this technically to be able to deploy and test these types of tools. So we have this end ecosystem that we've been building, but how did we learn? How did we actually start to put all these things together? So first is we partnered with Silver Hill Hospital to run a feasibility study with high acuity patients in a real clinical setting. There's nothing more valuable than actually taking your tools, the things that you're building, and putting them in front of the people who will actually need to be using it. So we gathered a ton of learnings, and I'll say on the right you can see the demographics. So we actually had 144 patients participating since the pilot began. About 76 have had a passive sensing via an Apple Watch that we've distributed to the patients. It's a roughly 50-50 between male, female, about median age of about 30, 32, 34 years old. But the learnings are the most important thing. Those are the things that we use in order to make sure that we are building the right system and that we know how to make it better and better. So as our first pilot, putting it in front of actual patients, we had a lot of things that we were learning. So the first is being able to see the data that you put into a system is incredibly critical. We heard from presenters earlier today just how important that really is. As a patient, you don't want to be using a tool and then see that your data is getting put in there and you have no idea where it's going. What is actually happening to that data? Is it being used in something that's going to be helping me for care? We need to be able to play those things back to a patient so they can understand that we are actually seeing them and that it's not just going into a black hole of oblivion. Other one, and this is important for high acuity patients at the hospital, blocking internet access is actually an incredibly difficult task with wearables that you do not fully control. Apple has done a really wonderful job with trying to add privacy controls and things in the loop to allow people to control what applications are available for certain amounts of time a day. And how do you give application developers, like really all of us here, the ability to control what people actually have access to? But if you're a patient and you're not supposed to be seeing your text messages, how do you set these things up to make sure that we as researchers and developers can actually get the data that we need and make sure that patients aren't exposed to things that could potentially make some of their situations worse. The other thing is tracking completion rates of tasks increases the completion rates of those tasks. So if you're telling somebody, hey, I want you to be part of this study, and we'll be giving you an Apple Watch for this, they'll say, okay, cool. But we need to make sure that we are telling them exactly what type of completion we need them to do. We need you to do it every day, and that we're going to be monitoring that thing. The idea of watching somebody and telling them what they need to do in order to get the cool thing at the end, the treasure at the end of the rainbow, is really, really important. And this actually goes into the incentive alignment piece, which is, if you think about where you would be deploying any of these tools, in spaces without clocks, being able to tell the time matters a lot. You need to know what are the things that really drive the people who are using the tools that you're actually developing. So if you know what they're driven to have, to feel secure, and to be able to use your tools, then you'll be able to get the data that you really need to be able to basically provide the best care that you can. But for high acuity patients, that's one group. But we also partner with other select clinicians, including Dr. Zach Cordner, to design an interface that is actually truly useful in a care setting. So we just started this about 6 weeks ago, so we have fewer participants, but 7 across 2 clinical practices. Again, roughly 50-50 for the demographics there. But the main learnings that we've seen from working with Zach in terms of developing all these interfaces, that, as we've heard earlier today, reports have to have a really consistent structure to make sense of the data. You don't want to be moving graphs around every time you add a new survey and then something changes order and it's alphabetized differently. You need to be consistent with how you present all this information to the clinical staff. Clinicians also often have limited time to digest data before going into a session. If you want to develop something that's really going to be used, you got to think about building a time machine. Is how do I make sure that I'm giving somebody back time to be able to look at and understand what they need to know to provide the care and have the conversations that they need to have with their clients and patients. So it could be somewhere between anywhere from 30 seconds before a session, depending on what's been happening before, to anywhere up to 10, 15 minutes. And if you have more time, then you can dig deeper into these reports and data and charts and things that I know we're all very interested in. We just saw an amazing talk by Sam Golden. And being able to look at those things is amazing. But if you're walking into a session, you need to be able to optimize for that time to tell people what they need to know. Also, some patients respond very positively toward having data. Others can push back and disbelieve. We got to think about how we're actually giving this information and presenting it back, and making sure that patients and clients can see themselves in the data. This goes back to the previous learning of the data can't just go into a black hole and then that's just off into oblivion. We need to make sure that people can see themselves in it and that we're having the right conversations. And the final is that we need to meet patients where they're at within our feature set. Maybe somebody actually really needs to be focused on how they improve their sleep, and we need to be able to expose that information and track that and show it to them so they can actually understand where they are. Maybe that's not important, but we need to have another feature for step tracking because we need them to start walking more or get out of the house. How do we add location tracking? We need to make sure that we're adding these features in to track the information that's required to make sure that we have the right conversations with patients and clients to be able to provide the best care. So to give you a little bit of like how the sausage is made, these are some early renditions from left to right, the earliest to the latest version of what our reports look like through conversations with our clinical partners. And you can see how we started to evolve from trying to think about like, what is the data that we want to show? How do we want to present this in a way that's digestible? We start out with, do we want to have some graphs on a cover page? Do we want to have a table with a ton of numbers on there? But then you got to read through it and understand where are these things? What if you had another survey? To finally what we have on the far right, which is what inspired the final interface that we have in the ecosystem. So all these combine together to create what really are the tools that we are presenting both to clinicians and clients and patients to be able to play back the information that they need to understand who is the patient that they're serving and how do we make sure that they can have the right conversations with them. So it's always really cool to talk about these things, but it's even better to see demos and how these things actually work. So this is our iOS app with the patient tools. You can see that we have tools in there to allow people to reflect on their mood. They can take their finger and drag around on this interface that uses moods based on the circumplex model. Even after entering that, you can provide a text-based interface like a journal, so someone could put in information about why they felt that particular way on a particular day. We have a library of different surveys, all clinical measures. But then as you see, we go into something like daily habits. Daily habits is actually a fully customized survey. So what are the things that need to be asked for an individual that you want to track daily, weekly, monthly, to be able to make sure that you're asking the right questions, gathering the data that you need to have the right conversations with them. So all these things are catered. You swipe down, you can fill things out, and everything from single choice, multiple choice, drop downs, and again, free text, because there's nothing more important than giving somebody the ability to explain what's going on with themselves in their own words. So after completing surveys through the day, we also, again, want to play back the data to the user. So they want to be able to see their data, that it's not just going into a black hole. So you see step count, heart rate variability, sleep, all these things we need to present back. Anything that we grab must come back out. But then Connect is a way to connect their data to their clinical staff and to be able to control what they see. All those little toggles there allow them to control what they have access to, including whether they want to track location or even share health data. So all of that is great for what patients see, but what about for the clinicians? So we need to generate the same type of reporting that we saw earlier for clinicians, but we want to make it something that is really usable. You need to be able to explore the data with your mouse and drag in and dig into like higher detail things, but we start with a high level because if somebody has 30 seconds, what are the most important things I need to look at? What are those call-outs I got to check? And then they can dig in deeper to see what are the steps in activity? How do I look through and see what those numbers are? Where are gaps? Where did somebody not wear the watch? Where was somebody not sleeping? Were they awake at an unusual time? How do I track that? Were they going for a run at 1 in the morning? Those are important conversations to have, including where someone is spending their time. Is somebody at home all of the time? Is somebody at work all of the time? And those are important conversations to have. We can also show all of the surveys that we're generating back for clinicians, including things like quality of life, BSL, HUDAS, which is one I know that was discussed earlier today. But then again, being able to visualize all of these trends, these habits, to see what days of the week, when were these trends changing? See that there's an uptick at the very end. Is something happening for this person at that point that's causing this trend to change? Those are really important conversations to be able to have, including things like mood. Where was someone's mood over different periods of time with like a heat map? Like are they typically feeling a particular way over some particular week, different from another? And then what are they saying about it? How do I look through and see like what are they saying about their personal experiences that are making them think or feel a particular way, so I can have them the right conversation with them to provide the best care. So all these tools are what we've built to be able to try to make sure that we are helping people get better faster, and really just to make sure that we are doing our best to make sure that people have the tools that they actually want to use. So thank you very much. I'm happy to answer any questions at the end, but I will pass it off to Zach.
Yeah, this is great. I was just kind of two things. One is for the outpatient use, are they doing this on their own devices? And then two, how are you thinking about EHR integrations?
Yes, good questions. So these are on their own devices. As we think about things like Apple Watch tracking, they have to be paired with that person's phone. So they are using their own devices, but we did figure out ways with things like kiosk mode to make sure that people, like at Silver Hill, do not actually have access to the internet and other things. But for EHR integration, right now we're focusing on making sure that we understand how these things work clinically first. That's the most important piece. And we're thinking about what are the options for things like EHRs, but there's so many out there. There's a lot of other things we got to get to first.
Thank you. What kind of feedback are you getting from clients?
So it's interesting. I'll leave some of the clinical pieces and client feedback to Zach and Andrew for that. But the things that we've heard do include like it is important to be able to see what is actually happening in someone's life, the conversations that do happen as a result of seeing the data. Think of it like storytelling. If one of us can remember something through some particular lens, but then you see the data that either might support it or conflict it, can be really helpful for either breakthroughs or understanding of oneself. So generally speaking, I'd say it's been positive, and we're always looking to get better.
And I think I have some more clinically oriented questions, but I'll wait.
So I see that you're collecting some open-ended text, and
Yes.
I'm wondering, like, how is that information being used? Is it being synthesized in some way? And if there is something concerning, is there some sort of like a real-time flagging capacity, or?
Yeah, so we're looking into a variety of things there. First is with any of the free text, we're using like open source models for doing analysis, things that we download and make sure that things are secure. That's obviously one of the most important things. The privacy is of utmost concern. But we want to use that to help more rapidly get to those insights to make sure that the right piece of information is elevated for clinical use. So we're exploring a variety of things right now in terms of interpretation of those things, but we also, as you see in the interface, we want to make sure that the raw information is available, that a clinician can always go in and see what was the actual thing somebody said. For things like alerts and concerning answers to things, we're working on how we think about the right types of alerts, because there's a balance between understanding somebody and what is normal, like maybe somebody endorses a high level of some particular response, but contextually the clinician who actually knows them and has a relationship, maybe they just know that that's normal. But we need to think about what's the right way to actually handle that, because if it's all noise, then it gets ignored, and if it's not, like, there's an important conversation that has to happen with clinicians, but it's ongoing.
I'm wondering what percentage of your data you're automatically collecting and what percentage is through questionnaires. And because not everyone is comfortable to fill out the questionnaire, if you only have access to the automatically collected, are you still able to provide some diagnosis or something?
Sorry, say that one more time.
So I assume you collect two sets of data. One is the automatically collected through ECG and those sort of things. And the other portion is the questionnaires and journaling and those sort of things. But not all your subjects are comfortable actually filling out those surveys, right? So half of your data might be just the automatic, whatever Apple Watch gives you. Are you able to actually provide insights based on just those data, or do you have to have the surveys filled out too?
Thank you. That is a good question. And ultimately, and going back to some things that Lindsay actually was saying earlier, is that we want to think about it as sort of like a prescription for individual types of data. So if we want to administer surveys, it's how do we think about the right ones to administer? Maybe there's somebody who surveys aren't the right thing for them, but there's other types of tracking that we can add that through a conversation with their clinician and the patient or client, that they know exactly what the right thing is. So we can still generate insights from the data even without having to have all of them simultaneously.
So sorry if I missed the portion about security of how this data would be dealt. But my question is, what is your perspective of how algorithms from different apps would integrate this data in their approach? For example, you see that apps for tracking periods are integrated with Amazon, and as soon as the period is delayed, Amazon starts to suggest like baby products, diapers, and etc. So how this approach could be safely managed to avoid the dark side of algorithms?
Sure. Well, I'll first say, we do not share client or patient data other than with the clinician themselves. So that's the first most important thing. Security is incredibly important. to us. So like HIPAA compliance, obviously SOC 2 compliance, encryption, all of those things are very important. It's one of the reasons we also have in that connect feature with the little switches to allow someone to control what they actually do share. We really believe that people need to have that level of control over it, and it is not up to us to be sharing that information for any reason other than for the benefit of their care with their clinician and the right authorizations from them. So no diaper stuff, none of the other marketing things there. Mm-hmm. Say that. Is there like small text in the consent form that says we're allowed to do that? Yes. No, if I remember correctly, we do not have anything like that in our consent forms that says, by the way, we can totally, no, we do not have data sales anywhere in there. No. Mm-mm. Amazing.
All right. Thanks, Rich.
Thank you very much.
Just going by the order, but we can do Zach next.
Hello. Well, thanks for being here, and thanks also for the summit organizers. This is a really lovely meeting. I've been coming to ACNP for a number of years. This is my first time at TIPS, and it's great to be with people who are able to think deeply about how to use this technology to improve the lives of individual patients. I'm a psychiatrist at the Mindwork group, and let me first tell you a little bit about the Mindwork group itself, and then I'm going to talk a little bit about our work with Tetricus labs using the Personally ecosystem. So we're a group of 3 psychiatrists, a neuropsychologist, a family therapist, substance use counselor, OT, art therapist, and recreational therapist, working out of Baltimore, Maryland, providing community-based intensive treatment. At the core of what we do is an intensive outpatient program focused on individuals who have very complex and often dual diagnosis issues, and we integrate them into a community-based program that offers about 20 hours of group therapy a week, a similar number of hours of individual therapy per week, and provides additional support in community housing. If you ask me what sets the work that we're doing apart from other care teams, it's really that we are truly multidisciplinary. When we got together and we thought, how should we build this group? It was clear to us that we weren't interested in reinventing any wheels. What we wanted to do is put the right number of wheels on the bus in an ecosystem where often the model is to figure out how few wheels you can use and keep the bus bumping along. So we brought together a truly multidisciplinary team, and we work side by side every day and provide intensive treatment to a fairly small number of patients who tend to be fairly acute. And we do that in part because we're able to do that in part because we have a 3-to-1 patient-to-doctor ratio. So we have 9 patients in our intensive program, 3 psychiatrists, and that allows us to contain an awful lot. And there's very little that can slip through the cracks when you have a 3-to-1 patient-to-doctor ratio and you're providing supportive housing for those people. We provide supportive housing in the community, which is intentional because we don't want to cloister these patients. We want them to be in the community, functioning as individuals, and we also want the community to see that this is good, and that providing this kind of care for patients in a community setting, I think, helps destigmatize the patients and the problems that they're facing in the care that we're providing. And I'll add that I don't live in the house with the patients, but I live 3 doors up. So that's an indication of just sort of the level of care and integration into the community that we're offering. We do this in a very data-informed way. So everybody who comes into our program meets initially with our neuropsychologist and completes a fairly comprehensive assessment that we actually take into the therapy space with every single patient. And we talk about that data as a group with every single patient at least once every 2 weeks. We talk about it as a group of providers at our weekly staff meeting, and we talk about it in a leadership sense, looking at aggregate data at least monthly to learn what we're doing well and what we can do better. And we look at outlier data to figure out where we may be missing things about our care model that either need to be improved or that need to be propagated. We also do this in a system that offers a continuum of care. So at the heart of the Mindwork group is our intensive program in downtown Baltimore, but we're also providing consultation services that have now a national referral base, and we're all licensed in a variety of different states and providing telehealth across state lines. And we have a very long-lasting set of relationships with patients who we've gotten to know over the course of the years. The patients who have been in our program or under our care for the longest have been under the care of one of us for over a decade. So we get to know these people over the course of a very long episode of treatment. So that's my day job. And in addition to providing psychiatric care at the Mindwork group, I also am the director of research, and we partner with a number of academic sites. I spent 16 years at Johns Hopkins before moving over to the Mindwork group and have a number of close collaborations there, and we're running a number of clinical studies. We're also in partnership with Tetricus Labs, and we've been using over the last number of months their Personally ecosystem. And I'd like to tell you a little bit about how that's gone in a real-world clinical setting. So, this is an IRB-approved study, so we do all of the right things. We consent the patients, we help them through setup, we assign them surveys, and then we assess their experience and utilize the data in the real-world clinical setting. So what I'd like to do now is just tell you a couple stories, because as a psychiatrist, that's in large part what we do in therapy. I mean, we trade in stories and help our patients make meaning of those stories. And in large part, what we're doing with this data is helping patients make meaning of it and integrate it into their story. So I'd like to just talk a little bit about how doing this has impacted the care of a couple of my patients. So I'm going to tell you about Lucas, which is a case of when truth set us free, and I'm going to tell you about Olivia, which is a case of when insight was unwelcome. So Lucas, he's a 25-year-old guy, grew up in the DC suburbs, excelled in some very competitive primary schools, was recruited off to one of the top public colleges in the country, where he was very much on the trajectory towards a career in medicine. And then COVID happened, and the world was turned upside down, and he was, like many people, thrown off of his trajectory. And he became very ambivalent about what he was going to do after college. And some of the things that he saw really very up close and personal as somebody who suffered with severe COVID led him to believe that maybe medicine was not the right career path. And he finished his degree, he did very well, but didn't really have a plan. Because he's a really bright guy, he landed a very good job with a fancy consulting firm in DC, and has done very well there. He lives independently. He's in a long-term relationship. And he was referred to me because he also happens to have really severe generalized anxiety disorder with panic attacks, and had been very resistant to taking any medications. So we fixed that. We got him to take some medications, and his anxiety improved tremendously. And I thought he was really thriving based on the reason he was in clinic to see me. And yet, what Lucas kept telling me is, I'm not sleeping, and that's making me depressed and anxious, and I'm not doing the work that I should be doing. I'm not spending enough time with my significant other. I'm not exercising. And I was confused because what I saw in clinic was somebody who was not depressed, didn't appear anxious, and I really couldn't cut through this in the usual way that we go about interacting with patients. So I said to him, we're doing this study. Why don't we get some more objective data on some of these things that you're telling me about? So we did that, and Lucas provided us quite a bit of data. This is all just to say that Lucas gave us a lot of data, we got step count and sleep data and surveys and mood ratings, and he's been very reliable about giving us lots and lots of data. And you've seen the sort of fancy interface that we have access to. I'll say, as a clinician, it's really a lovely balance between access to rich data and functionality that I can bring into the clinical setting in a very efficient way. So this is some data from Lucas, and what you can see is that Lucas was sleeping 8 to 9 hours a night, despite the fact that he was complaining about not sleeping. His GAD-7 score, a measure of anxiety, was actually 0, and his PHQ was very near 0. So he kept coming to clinic saying, I can't sleep, it's making me depressed, it's making me anxious, and I'm not thriving. And so we collected this data, and it really created a very interesting conflict between the data that we were seeing and what he was reporting. And he also rated his mood on the mood map, and this sort of confirmed that his mood was fine. He was rating his mood as happy and content, and described how he was having good days planning a housewarming party, and excited about having a lighter day at work. And we also saw that when we dialed down on the sleep data, he was getting plenty of REM. He was going to sleep at about the same time every night. He wasn't waking up in the middle of the night, and when he was waking up in the morning, he was in bed still at 8:30. 9 o'clock, sometimes a little after. And this is a guy who's supposed to be at the office 7:30, 8 o'clock. And then we also noticed when we looked at the activity data, the step count data, that this is a young, healthy, really athletically capable guy, and he was barely moving throughout the day. And I took this back to him, and we just looked at the data in a clinical therapeutic session. And what we actually got around to, now it wasn't like a switch flipped. This is weeks of therapy. But looking at this data, got us around to the fact that, like, actually, yeah, he's sleeping fine. He's not depressed. He's not anxious, but he's deeply ambivalent about the job that he's taken. And he revealed to me, I didn't actually know it at the time, he revealed to me that he had started working from home full time, which explains why he wasn't moving hardly at all. And this has opened the door for deeper psychotherapy with Lucas to explore, like, well, what does he want to do with his life? And, like, what story is he telling himself about, like, his experience in college and his career path, and what does he want to do going forward? So, you know, this is a story about how using this kind of data really set us free in therapy. Now, I'm going to tell you another quick story about Olivia, which is a story of when insight was really very much unwelcome. So Olivia is a woman in her early 40s who grew up in profound privilege, but with a parenting style that I think is best described as intrusive neglect. So her father, a serially successful businessman, sort of interacted with her in the way that, you know, a hedge fund manager might interact with an investment that he can't offload, but that isn't providing much return on the investment. And her mother interacted with her in a very unpredictable way, in part because of her mother's own psychiatric problems, including severe substance use. And her mother and her father were really quite literally at each other's throat throughout much of her childhood. So she witnessed quite a bit of trauma. And Olivia has borderline personality disorder. And she spent the first 15 years of her treatment trying to sort that out. And thankfully she did. She's now a faculty member in speech pathology at a local university in Baltimore and is getting a PhD in bioinformatics, in large part because funding agencies don't know what to do with these grants that she keeps writing that employ fancy bioinformatics, but she doesn't have a PhD in it. She came into the intensive program after the death of a grandmother who was really, by all accounts, really sort of a saintly figure in the family. And in the context of that, Olivia reignited her very sophisticated ways of making chaos in her life. And she wasn't attending to work, she wasn't attending to school, and she sort of rekindled some problematic relationships that she had had from the past. And I said to her, I think you would really benefit from getting some objective data and bringing it into the therapeutic space so we can understand the way that you are spinning all of these different plates. And she agreed to do that. But Olivia gave us very little data. We got some step count data. She didn't provide sleep data, didn't fill out any surveys or rate her mood. She did, however, turn on location tracking and allowed us to assess that. And we got a lot of location data. We did, as I said, get a little bit of step count data, and this is hers. And what I'm going to point out is that the pattern here is that there is no pattern. It's a little bit hard to see because she's moving around throughout the day, but there are these times when presumably she should be at work or at school. Sometimes she's supposed to be at the office and missing her appointments. And she's I don't know where she is, but she's sort of constantly on the move. And then there are these times when she's up, it seems like all night, and going to bed at really sort of unpredictable times throughout the night. And just to sort of drive this home, we also were able to take a look at her location data. And I put markers on here, this is where she lives. She can walk to work. She can walk to her PhD program. And this is where the Mindwork office is. And it's not that the therapy had any intent of restricting her movement, but we did talk a lot about blocking her time and finding hours in the day to do her work, do her school, come to the office for intensive treatment. And what you see is she's spending time all over the Baltimore Metro DC area. And we know a little bit about some of this. Down in DC, you see there are sort of, it's down in the bottom left-hand corner, there's sort of two places she seems to be. Those are both X's. Out here on sort of the eastern shore, that's where her father lives, and that remains a very problematic relationship. And she also was at the Baltimore-Washington airport like 4 or 5 times, and I still don't have a great explanation for that. So I presented this to Olivia. We brought it into therapy session and looked at this data. And she said, no, thank you very much, fake news. And you know, her response was very much sort of a dissociative type response to this data, that like, this is too much, it's fake news. That's sort of the bin it got put into for her. So, you know, she's still coming to treatment, and I think we're making some progress, but, you know, this is a case where this kind of technology really faces quite a few hurdles in practical implementation. So I've told you these 2 stories, again, contrasting the utility and some of the barriers that technology like this faces in real-world implementation. But what I want to leave you with is that this is what real-world implementation looks like. You know, I spent a number of years down at Hopkins where we had a lot of widgets, but the widgets sort of stayed within the walls, you know. And here we're doing sort of psychiatry in the wild and implementing this technology into what looks like real-world clinical practice and understanding how this work impacts the lives and the therapy of individual patients. So with that, I'll thank you all very much.
Questions?
Well, thank you very much. In a sense, that's an unflinching report, right? And you answered sort of the questions that I had earlier. It's, but I also want to commend you, and it raises the question of, you know, as one starts to do or try to implement in real-world settings more data-driven assessments and feedback to individuals, how you might consider, you know, I was very struck by that you do neuropsychological assessments. You know, in the general field of clinical practice, we don't give people feedback about cognitive strengths and areas which are not as strong. And we know that has huge implications for engagement in work and therapy and other kinds of activities. Likewise, we don't usually give any kind of assessment or feedback to individuals around some of their inherent trait-like kind of motivational capacities, you know, whether they are more reward-driven, kind of more punishment-driven. And so I've just been, the reason I ask is because we've been playing around with those ideas with early psychosis individuals and gaining some traction, but I'm wondering how you've been thinking about it in your own practice.
Yeah, well, thank you for the question, and you know, keep up the good work. It sounds like you're doing some of these very similar things. I think this is, you know, it's critical to bring any of this data like back to the bedside, back to the therapy space, back to the work. You know, now at worst, like collection of this data is sometimes used as a way to sort of like satisfy regulatory requirements and nothing else. And that, you know, is not necessarily just benign. Like, there can be, like, I think, real detrimental effects of, you know, practicing in that way. So, like, our whole model, the team's model, is figuring out ways to collect this data and efficiently bring it into the clinical space. And, you know, before we started to partner with the Tetricus Labs team, you know, we were doing this and we were, you know, getting detailed neuropsychological reports on everybody. But as you probably know, it's incredibly time intensive to do and then to interpret and then to bring back to the patient in a understandable therapeutic way. What this is doing is accelerating that in a way that I think is really very important if we're going to, you know, reach scalability. Like we're a small group practice, sort of a boutique style practice. We can do this. We can get neuropsychological batteries on everybody and make sense of it. But not everywhere can. I think that the work that the Tetricus Labs team is doing actually allows for scalability beyond practices like ours.
But there are now a slew of brief digitalized cognitive assessments which you can give in a very short time frame and create reports back on. Just a comment, and I think, I'm going to paraphrase you because what you've done, and again, I think you really described it very beautifully, is you're bringing the information back into the clinical setting, back into the relationship, actually, back into the therapeutic relationship. And I think we often lose sight of that. Yeah.
So you just mentioned that it's not always positive. It can be negative. And thinking about like Olivia's case, when you say that when you showed the geographical data, she was like fake news. My question is, did she continue sharing that kind of information afterwards, or did you like face any resistance? And would that be a problem? Thinking like the future of this kind of application?
Well, I mean, I think any psychiatrist or therapist will tell you that like step one is alliance building, and we do that very intentionally before we, implement any of this. So we have a very good alliance with that particular patient. This didn't lead to a rupture in that alliance. I think in part because of the containing environment that the intensive program that that our particular group offers, and the fact that this particular patient does have some insight into this reality. It was too much up front, all at once. And that's something that I think I need to learn about. But thankfully, the confrontation with that data didn't lead to a rupture in the therapeutic alliance. But I can certainly imagine cases where it would.
Other questions? All right. Thanks, Zach.
Thank you all.
Okay, we'll come back to it.
All right. Well, thank you for having me. So let me start with something a little bit about me. So I have to savor this moment. I've been coming to TIPS since the very first year, and this is my first time presenting, so I'm very excited to do that. Thank you, Phil. I am a huge fan of this conference. It's my favorite conference of the year, and I think all of you understand why, because of the extraordinary things you get to learn about and hear from so many people. So I'm thrilled to be part of this. But I have my own kind of journey, no conflicts of interest. But let me just tell you a little bit about my journey and sets up a little bit of my approach to the questions that we're trying to answer today. So I sort of have loved technology and sort of loved hard sciences for as long as I can remember, but sort of caught the bug of mental health and trying to understand the mind and brain when I was in college. So decided to pursue this career in psychology and in psychiatry. Trained in places where we learned how to do great treatment. Like many of you, like lots of people out there, left with this somewhat idealistic notion of the possibility for the future because of all these things we have. Medications, psychotherapies, and in some cases psychotherapies are even more applicable to lots of the disorders that we're talking about. So promising to go out and do these things. And then reality kicks in when you finish your residency and you realize, and someone said this earlier today, that our ability as a field, as a society, to apply the best techniques, the best treatments to individual patients in a way that is tailored to them is tragically, bizarrely hard in mental health, and I would argue probably harder in the mental health field than in any other of the medical fields. So when we think about why, and we all hear this all the time, the country's in a mental health crisis, that the various metrics, with very few exceptions, are getting worse, not better, in terms of depression, anxiety, suicidality, a host of other measures. To me, that's not a surprise. And it's not a surprise because we as a field, as a system, are not doing a good job. And often when people, and I know it's true of some of us in this room, have had really good training, you face this choice when you finish your training, which is, do I work in a place that lets me be the kind of, in my case, psychiatrist that I want to be, but I can only care for a small number of people. Sometimes that means only caring for the relatively mildly ill, so for example, in a solo private practice, and often only care for people with the resources to pay privately. Or do I say, you know what, I'm not going to live in an ivory tower and I'm going to work in a clinic or a hospital setting where I can't do the kind of psychiatry I wished I could, but at least, you know, I'm in the right environment. It's a choice I know a lot of people have had to make. And frankly, most people I know have chosen the first. And so colleagues of mine who I think very, very highly of, that's what they're doing. They're in private practice in a place like New York or Boston or LA, and they're treating patients well and individually, but it's a small number, they're relatively well, and these are folks who can pay privately. So that drove me crazy. And I stubbornly said, I don't want to live my life and make that choice. So I kind of took another path. I went and did research. I ran the MRI Center at Columbia Department of Psychiatry for a while, did private practice on the side, worked in a clinic, and kind of a mess of things. But in 2015, so almost 10 years ago now, I tried something different, which is I took a job running a small psychiatric hospital in Western Massachusetts in the Berkshires called Austin Riggs. We don't have time to go into the whole story about what Austin Riggs is. It's a strange little place, but it's nice in the fact that I got to put on a conference and invite Justin to come, which was I think our first time meeting in person, which was a lot of fun. But then a few years later, in 2018, I moved to Silver Hill Hospital. And Silver Hill Hospital, which actually was started in 1931 by people who had trained at Austin Riggs, is a private, nonprofit psychiatric hospital in Connecticut. New Canaan's just about 45 minutes to an hour north of New York City. And it is what I call a continuum of care, meaning it has inpatient, it has residential, which means patients live on campus but are not in a locked unit. They're often in very nice circumstances, and outpatient as well, all on this one very beautiful 44-acre campus. Even though in the sort of popular imagination, Silver Hill is often thought of as a place only for the wealthy, that's actually not true. Our inpatient and our outpatient services up in New Canaan are insurance reimbursed. They both lose money terribly, because if you're insurance reimbursed and you offer high quality treatment, in general, you do. But the way we do it, and we call it the Robin Hood model, is we subsidize those programs from the residential, which is a private program. And that's a model that we've used really since the place started in the 30s. So that's, for example, one of our buildings. It's a very, very pretty place. We treat about 2,000 patients a year. So I started there in 2018, and have really, really enjoyed being there. But one thing it lacked was a presence in New York City. And a couple years ago, an opportunity became available. There was a program, a very high quality program that was started back in the 1970s called the Freedom Institute, that had been in Midtown Manhattan since then, specialized in substance use, but really had done a very nice job at offering high quality care for individuals with substance use and comorbidities, so people with Axis 1, so major depression and anxiety, but people with personality disorders as well. And had hit hard times, particularly around COVID, started to lose money, and ultimately the leadership said, we can't continue to do this, so we're gonna look for somebody to buy us. And they approached us at Silver Hill, and this was our opportunity to move into a new space. So this was a very exciting opportunity. The question then became, what do we do with it? And anybody who's attending Lindsay's program earlier remembers her talking about, the opportunity of starting something new is pretty intoxicating, particularly when you've worked in a large system that was started in 1930, where plenty of places, McLean's been around a lot longer than that. Yes, you can change things incrementally, but you're dealing with a lot of history and bureaucracy. You're starting a new program, and because we had purchased Freedom and we're planning to rename it, we really had a chance to do something new. So the light bulb kind of went off, and Lindsay and I had already been, and Rich and I had already been working together because of the collaboration you heard about earlier up in New Canaan. I'm not going to talk about that now. And I don't even remember when the first conversation happened, but one day we said, what if we were to switch course? What if we were to start a brand new program from scratch that has not only the best care in terms of the psychotherapies and other treatment modalities that it offers, but it integrates data from day one. And that's just baked in and built into the culture. That was our dream. So that, we decided we were going to do this, and it gave us the opportunity to really kind of think about how we wanted to. So one was, what are the principles? What are we solving for? And from early on, we said there were these three big things, that even though lots of us love methods, I love methods, I think probably everybody who comes to this conference in some regard loves the technology and the methods. We said, we're not going to let the methods rule us. We're going to have principles. And these are the three. Number one, we want to personalize the treatment to the individual patient, right? In most of medicine, certainly in private practice psychiatry, that's a no-brainer. Of course you're tailoring the individual therapy to the individual patient. Yet in institutional settings, hospitals, residential, IOPs, more often than not, obviously I would exclude Mindwork, which is also an extraordinarily different and amazing program, but more often than not, it's cookie cutter. It's this, everybody gets the same thing. And you can imagine why. It's a lot less expensive. It's a lot more straightforward to do it that way. And we said we're not going to. We're going to personalize. Number two, we're going to place the patient at the center of their care. And of course, that's a very popular thing to say. You hear it on every advertisement for every healthcare thing you could imagine. But as you might imagine, actually doing it is another matter, which is how you have to give patients real choices. You have to give them real information. You can't ask people to be empowered or expect them to be empowered if they don't know what the hell you're talking about. So that's really quite a responsibility to empower the patient. And third, and in some ways most importantly, we had to have a system that created an iterative learning cycle, so that everything we did, we could measure what we're doing and then feed it back. One of the most shocking moments I had when I was in my training in residency was we would do all these things. A lot of our time was spent in the emergency room treating patients. And the patients would go out the door at the end, and you would never see them again. And you had no idea whether you'd been helpful to them or not. And I just thought, that's the setup for bad care, if you can't evaluate the treatment that you're giving. Now, you might even argue in some cases, probably the system didn't want to know, but I will tell you that it's demoralizing as a clinician when you want to give great care, and yet there's no way of getting feedback. So we wanted to build learning in from scratch. So as we were thinking about these principles, we started to design what we wanted the process of entry into the program to look like. And it's funny because, again, some of these things might sound like, well, of course things should work this way. Why wouldn't good treatment always work this way? Yet, when you've worked, as I think Zach just used a great line, or maybe Rich used it, psychiatry in the wild. I love that phrase. We should have like a T-shirt or something. But in psychiatry in the wild often doesn't do that. In the wild, what happens probably more than anything is patient walks in the door and they get whatever we have, right? We have a therapist there, they get that. We have medications, they get that. And before you know it, they're getting a treatment. We haven't fully assessed them. We haven't gathered all the information. We've certainly not collected all the kinds of wonderful data that we're talking about today. And we haven't conceptualized. So you can imagine what happens if the treatment doesn't work. You sort of don't know what to do next because you've never thought it through. What can you do? You try something else. And I think patients intrinsically know that a lot of the treatment that they're being provided is this kind of almost, catch as catch can kind of trial and error approach as opposed to systematic. So we said, we're not going to do that. We're going to have an admissions process that is systematic and careful and take the patients we can help. We have an assessment process that tells us what are all the different sources of data and how are we going to gather them, and now we're going to gather them. We get together as a team. We call it the case conference. In the old days, when patients stayed longer in lots of places, this was routine. It has mostly evaporated in a lot of psychiatry, but they'll get the whole team, the multidisciplinary team that Zach was telling you about before, together. We're going to synthesize the data. We're going to then review it, not just with ourselves, but with the patient, him or herself, and do it in a sensitive way. And only then will we really think of the treatment as beginning. Now, you might say, well, does that mean you're waiting weeks before starting the treatment? And the truth is, no, we're doing a lot of this stuff in parallel. In fact, the assessment itself is kind of an intervention, and patients report all these assessment and all the attention and being part of the case conference, which they're invited to as part of an interview, and so on. They report that as feeling like the treatment is already starting. And then, of course, that's not the end. It's cyclical, right? So the treatment is now, when there are questions, is feeding back into further assessment, further case conceptualization, if necessary, another case conference, treatment reviews, and so on. That's good treatment. It's become incredibly rare to do treatment like that. I think you're getting a very unusual sample. It's happening at Mindwork. It's starting to happen now at Silver Hill, New York. But I really wanted to express how intrinsic this is to the whole process. I did want to say just a little bit more about psychoeducation, because in a way, psychoeducation in our field has become almost a throwaway term sometimes. Like, check off the box that says we did some education. What does that mean? Oh, we told them that there's a chance that they'll have, headaches on Prozac, or that they'll have some weight gain on Depakote, right? That's not what we mean by psychoeducation. What we mean is helping collaboratively build a framework with our patients that we can use a common language about what we think the problems are, the questions we still have, why we're trying these treatments, and now what we're learning from testing things and so on. So what I hope you can get a sense of is, I haven't even said anything about an app. I haven't even said anything about the technology of data gathering yet, because in some respects, to my mind, it becomes obvious once you use a framework like this one that the current state of the art of what we can collect through all the data techniques that you've heard so far, not just in this seminar, but in others, are natural pieces to this, right? Some of the practices I'm talking about have histories that go back many decades, and they were just as relevant then, but we didn't have all the great technology back then. So let's resurrect what really great mental health care is and psychiatry is, and now let's use our technology as part of that. Last but not least, I did want to say something about the learning system. And this goes back to that last item I mentioned of how do you create a system that's constantly feeding back on itself. And I think it helps to think about 3 levels of learning when you're talking about this. Because you have a clinical team, and that clinical team is the providers, the interdisciplinary group that's right around the patient, the therapist, the psychiatrist, the social worker, the family therapist, the activities, the art therapist, all of those folks who get together to talk about it. And they learn together about individual patients, but then they develop a kind of routine. Anyone who's been to these rounds knows what it's like. They say, you know what, this patient, he reminds me of John Smith, who we saw 3 years ago. And teams that have been together for a long time, it's amazing how much they'll remember. They'll remember someone from 15 years ago, and everybody will say, like, oh my God, you're right. And remember what happened with him? So that's a kind of inter-team learning. You can improve that with new methods, right? It's not enough just to think you remember a case or even to go back and read old notes. To have data changes that. But now you have an environment around them. How do you build a set of meetings? And so this is what we're doing actively. And with Lindsay as program director, it's kind of an amazing activity when you've got, I'm clinical director, Lindsay's the program director, Justin and others are working as psychiatrists and consultants on the team, and we're having these conversations about, well, what meetings do we need? How do we use our meetings in optimal ways, right? None of us are going to sit around and have a meeting just to have a meeting. These have to be valuable. And we use them to learn, not just at the level of the clinical team. That's one meeting that has gone on anyway. But what other meetings do you need? Do you have the whole staff? Do you have consultants? Do you have to learn more about specific things? And then again, how does data come into that? What do you record? We haven't done it yet, but how are we going to use automatic transcription and large language models to synthesize data that comes out of our meetings and out of interactions with our patients for the long term? And then ultimately, how do we scale this system as it grows? Because I think it's essential that we start small, just as Mindwork and Zach has done, and we have done, we're similar size at this point, 10 or so patients. But the goal is to build this into something that can be scaled so that the millions of people out there who need this level of care, and it really is millions, have access to what we think is essentially a superior treatment model, and we hope will become a standard of care in years to come. Certainly, one needs values to go with this. Some of these you've heard already. When the technology is included, we believe strongly in there being transparency, clarity, privacy, and security, as has already come up. Meeting patients where they're at. The notion that we're just going to impose the wisdom on them wouldn't work even if you tried it, but it would be a bad idea nonetheless. And usability of all the apps. So that sort of gives you a sense of the sort of principled approach that we've taken to building this program. My fantasy is that in 5 years, there are going to be a bunch of these around the country, and maybe in 10 years or 15 years, this could be the emerging standard of care. And we're going to look back and think, can you believe there was a time when it was sort of hit or miss, and we kind of remembered what we could, and we didn't measure anything, and we'll think, you know what, that was kind of like using leeches. That was the Stone Age. And I think we'll be right. But there's a lot of work to be done, and I think environments like this and all the people who are here, we're all doing pieces of this great work. So thank you for listening to me, and I look forward to your questions.
Any questions for Andrew?
Hey, Cheryl.
Nice talk, Andrew. I was very quickly. Have you considered audiovisual recording of your clinical encounters as a way to collect data?
Yeah, I may defer a little bit to my group here. I mean, I'll tell you from my perspective, we would like to create an environment where that is so much just part of the culture that it's sort of not a big deal. We talked about wiring certain rooms for a variety of reasons that was hard to do. We have been using an owl recently, and I kind of love the owl. I don't know if ever people have used the owl. It's this great little cylindrical device, kind of looks like an owl, and you stick it in the middle of the room, and it has cameras around it. I think we're still getting our sea legs a little bit in how do we introduce it to patients. And I think of it as threading this needle, which is we want to introduce it with enough authority that we kind of expect them to do it. We're not forcing people. We're not going to throw them out if they won't. But we of course, don't want to do it in any way that feels coercive. So at this point, we're still kind of navigating that. What we'll do with that data, I'm not sure. But maybe I'll kind of look to the team. And Lindsay, Justin, Rich, I don't know if you want to say anything about your thoughts about how we get that going and ultimately what we're going to do with that data.
Yeah, I can comment that, part of we motivate it by letting them know that it helps me write my note, right? So it's sort of like, this isn't a research thing. This is just for me, it helps me do my job a little bit better. That doesn't always fly with every client. I've had clients who have said, it's still creeping me out. Can we just not do it? And it's a negotiation each time with some clients. Other clients are like, sure, whatever, I really don't care. But it's, I think it's one of these it's a little bit different than, I'd like to monitor your step count. I think people are understandably hesitant. When I've asked clients, why are you hesitant? It just changes the way I feel comfortable sharing what's going on with me. So.
Yeah. I can't resist telling one Menninger story about this. Michelle, I don't know if you know this story, but when Menninger was in Topeka, Menninger is also one of these very old psychiatric hospitals, for anybody who doesn't know it. One of these great, great hospitals. When it was in its previous campus in Topeka, Kansas, somebody, and I don't know where they got the funding for this, had built this amazing video studio. So when I was a medical student, so this is about 25 years ago, I did a rotation in Topeka, and part of the rotation was you recorded interviews with patients. And it was the first time I'd ever done that, and I was scared and freaked out about it, but it was not a choice. And I remember going into this studio and then recording 2 interviews with 2 different patients, and then I had to watch the entire video with one of the psychiatrists and go over everything I did. And as anyone who's ever done videotaping knows, you're nervous at first, and then you get used to it, and then it's enormously helpful. And I know there are plenty of training programs that do that. There are plenty of training programs that don't. But I think we do have to shift the culture to where this is just part of what we do, and for all the reasons that you can imagine, becomes this treasure trove of data.
Obviously, all of this work is sort of near and dear to my heart, but I wonder, do you have any job openings?
We do.
Because I work in a healthcare system where over the PA system, there's 5 code greens being called out in any given day down in the ED, and the waiting list for the child services is 2 years and so forth. So it's kind of slightly different, and we're still trying to figure out ways to implement measurement-based care. But your comments and your readiness to do this and to do it right have made me think, again, this is more a meta-level comment for all of us who are very interested in this in the field. There's measurement-based care that we can implement, and some places are implementing it now, which is, how would you describe it? It's not necessarily mechanistically tied to anything we know about what's generating the actual maladaptive behaviors themselves. And I think where we all hope to go, and I know Justin's work and the work of others, are really trying to make us think about what are the measurements we could put in, which are not just descriptive,
right,
and not just something that are going to be part of a dialogue, important as that is, but they're actually going to give us insights into deep personalization in terms of some of the underlying neural system mechanisms and perhaps psychological mechanisms as well, right, that are affecting an individual's trajectory. So I kind of just wanted to make that meta-level comment because we're not quite there yet, right?
You're 100% right, and this is the danger of so many of these sort of kind of trends. People hear measurement-based care and they automatically think, oh, check that box. But a lot of measurement-based care, to be honest, is kind of crappy. And I have a psychiatrist who loves to get under my skin a little bit because early on, when I first arrived, I said, all right, first I just have to get measures into the place. We weren't collecting any measures. So I got a set of self-reports in for every single patient every 2 weeks. And it's not the whole picture, but at least it was a start. And she happens to run our psychosis program. And so she loves to forward me the reports that I generate, which are the self-report checklists from her psychotic patients who say, everything's great, and everybody knows they're some of the sickest patients in the hospital. And she's right. It's a joke that that's measurement-based care. But then you compare it to what you're seeing from Zach and from Justin and Rich and Lindsay and everybody else here, this array of things. So for some people, the GAD-7 and the PHQ-9 are super useful. For some people, it's their sleep. For some people, it's their coherence of self-identity. For some, it's where they go and what's going on at the airport and all this other stuff. I think that, listen, it's a lot of why we went into this field, because it's interesting and complicated, and it's not just one metric. It's not glomerular filtration rate, It's way more complex, but that means we need multiple sources of data. And these systems are all built to iteratively add new measures and ultimately to have different patients following different metrics, which is what we need.
All right. Well, thank you, Andrew.
Thank you.
And our last presenter today, Michelle Patriquin.
Okay, thanks for hanging in there. I'll make this as interesting as I can to talking about data, technology, which I love. But so I'm going to talk today about data into practice in intensive mental health settings. And when I talk about intensive mental health settings, I mean inpatient. And I mean data into practice through technology. My role now, Andrew referred to Menninger. I was at Menninger and Baylor College of Medicine for the last 10 years and just recently transitioned to University of Texas Health Houston. There, I'm co-director of research for the John S. Dunn Center of Behavioral Sciences, and we are the largest academic inpatient psychiatric hospital in the United States. At any point, we have between 450 and 500 inpatients of all levels of at all levels of care, including outpatient, some outpatient services. We have a highly diverse patient population, voluntary, involuntary, very diverse payer mix as well. And so it's a very interesting hospital, and also incredibly important, and to think about measurement-based care within this setting. And that's some of what I'll talk about today is how we can take findings that we have been working on at Menninger and Baylor College of Medicine and really apply them to what we, the patient population at UTHealth Houston. Another role I have is Assistant Dean of Digital Health and Innovation for our new School of Behavioral Health Sciences. And if you have any trainees, I'm going to do a little infomercial. If you have any trainees who are interested, PhD programs, master's level programs, please have them look at our new School of Behavioral Health Science. Our hope is that we have our first incoming class next year. And our goal and my role there is to really infuse technology, evidence-based use of technology into our curriculum across all programs. Our goal is, especially for those who are doing clinical work within intensive mental health care settings, like inpatient, have not only are highly trained in terms of their graduate curriculum and highly trained within inpatient or intensive mental health settings, but that curriculum also really infuses technology, the evidence-based use of it, the science, the practice, into really integrating that into care in an effective way that improves the outcomes for patients. So please look at that too. So when we think about outcomes for inpatient, I really like World Health Organization's initiative for last year. They talked about that everyone has the right to available, accessible, acceptable, and good quality care. It got me really thinking about how do we define good quality care? Who defines that? And the Lancet last year just at the beginning of this year, there was this really nice, just 2-page paper, if you haven't read it, reporting lived experience work. And they talk about the importance of including those with lived experience at the same exact level of the scientists as the clinicians, and that's how we should be defining not only our science, but also how we measure care, what matters to patients, and really thinking about that and having that at the same level as everybody else, all the other stakeholders. And so this quote says, "The expertise that comes from living experience is as valid as those from the standpoints of working with, caring for, researching that experience." And so that we need to take that into account. And I was so proud, we had a symposium earlier where we had those who are doing science, who are doing clinical care, and who had lived experience all on that same panel, all on equal footing or on the same stage, which is really important. So something that we have been really interested in is what do we measure? So we were kind of talking about that. And you have to measure what matters, and especially measure what matters from the patient perspective. You also have to measure it well, right? So psychometrically valid measures with norms, measures that make sense to the patient, make sense to the clinicians. You also have to adapt to the patient. And I think this is really important when we start to think about how do we leverage new technologies or existing technologies for a new use case, and how do we adapt what we do so that patients actually use it and find it useful. It's incredibly important. So former US Surgeon General is pretty famous for saying drugs don't work in patients that don't take them. I think you can edit the same thing. Measures, technology, wearables don't work in patients that don't use them. If they're not going to use them, it does not matter at all. It doesn't matter the cool software you've designed or the incredible algorithm that you think that you have created. If no one uses it, it really doesn't matter. And it's important for clinicians and for patients. So really having those stakeholders in mind. when you are thinking about technology or measurement-based care outcomes. So this is just a definition of measurement-based care, which we were kind of talking about earlier. So, but just from start to finish, use outcomes to inform and adjust mental health care. And in case you don't, you might be cooler than me. I didn't know what TLDR meant until this presentation. And so I Googled it for those of you who may not also know. Too long didn't read, who knew, right? And I've been on Reddit for so long, and it's always on there. I never Googled it until now. So, but it use outcomes, right? And so, but what outcomes, and for who are they important for? But then also adjust and iterate someone's care based on that information. Whatever information is considered important for that care, and it has to be a fundamental element of evidence-based mental health practice. So today I'm just going to go really quickly, because I have 5 minutes, through some research that we have done on outcomes data. All of this comes from the Menninger Clinic at Baylor College of Medicine, where we had a very systematic clinical outcomes protocol where from admission to discharge into follow-up, 2 weeks, 3 months, 6 months, and a year post-discharge, we tracked symptoms, patient-reported symptoms of mental health throughout their length of stay as well as post-discharge. And I just encourage you to check out these papers where we agnostically determined mental health trajectories throughout someone's length of stay and looked at impact and the relationship of those outcomes to post-discharge outcomes, as well as determining what was working and for whom. And not an average across time, right? So we looked at these mental health latent scores where we collapsed PHQ-9, GAD-7, different measures that we're measuring throughout someone's length of stay. We collapsed it into an overall construct of mental illness and looked at how that changed over time. Because when I would do family sessions and then I would give these family education presentations, I would present these beautiful averages across time of people improving throughout their length of stay. And family members would say, well, that's not what my family member is doing here. They are not improving throughout their length of stay. They are still struggling, and it's weak. We have 4 to 6 weeks length of stay at the Menninger Clinic, and so it was very invalidating, frankly, to look at just averages, and it wasn't actually what was happening. And so that's why we started to really think about different approaches to analyzing that data that were more agnostic. And so these 2 papers, the second one is a replication and a separate sample with those same type of trajectory modelings. We also looked at, for the first time to our knowledge, how inpatient suicide risk levels related to death by suicide post-discharge. Death by suicide post-discharge, one of the highest risk periods in someone's entire life for death by suicide. And so really connecting, we were the first group, we believe, to connect every suicide outcome, ideation, attempt, and death. And we found that those at most high risk for death by suicide were this resolver group. So the group that responded fastest in terms of their suicide ideation actually were the most likely to die by suicide post-discharge. So that non-responder group, not as likely to die by suicide post-discharge. The responder group, also not as likely. It was that rapid responder group or resolver group where we do have people who are actually truly getting better in terms of their suicide ideation, but we also have people within there that are our highest risk group. And so we called it a false sense of security, so rapid improvement as a red flag for death by suicide. And it just really highlighted for us the importance of data, frankly, and examining this data across time. At Menninger, all patients are voluntarily admitted. We don't have involuntary patients, and so it is a different patient population. They are able to self-report for the most part, but it really gave us some initial insight into some of these trajectories and how they relate to outcomes, especially post-discharge. But there's major implementation barriers. There's a lot of time and effort that takes to administer, interpret data. There's knowledge and skills for correct interpretation, application of outcome results. And there's a lot of negative attitudes, actually, towards measurement-based care. It's partly because it's so time-consuming, particularly in inpatient. And there are a lot of other factors at play. So earlier this morning, we heard from a nurse leader who was really talking about, especially for inpatient, nurses, she quoted something like 85% of kind of nurses in their day are experiencing workplace violence, or some quote like that. There is a tremendous amount of violence. So nurses are actually afraid first for their safety, right? We think of Maslow's hierarchy of needs. Safety is going to be number one. If people don't feel safe, they're not going to administer your survey. So there are major barriers, but it also can provide tremendous insight. And so something we've really thought about is how do we take lived experience, self-reported data, outcomes findings, turning it into intervention. And something we've really thought about is sleep disruption and sleep disruption inpatient, particularly because we have a lot of different findings. These are papers we have published on the relationship between sleep and mental health for inpatient, and I'm just gonna kind of ruin the whole suspense of this all. And what we find is sleep really matters for mental health while inpatient and post-discharge from inpatient. And so we have a variety of papers on that with trajectory modeling and different kind of modeling where we really identify sleep as the strongest predictor of suicide risk over and above everything else that we know is associated with suicide risk for inpatients. A lot of those things like depression, anxiety, suicide attempt prior to admission, suicide ideation prior to admission, all of those are strong predictors, nothing above and beyond sleep. And so it gets kind of confusing because when somebody is inpatient, we disrupt their sleep a lot. We do things called Q15 checks or rounding, where we go into someone's room and qualitatively, patients report all the time that this is very disruptive of someone's sleep. So we're kind of doing like a sleep fragmentation on people who have pre-existing sleep problems. And if you remember, suicide risk is one of the highest risk periods is post-discharge from inpatient. So, right, we are doing sleep fragmentation on people with significant mental health issues on a treatment target area that it could potentially be related to that death by suicide post-discharge. So we know from data, ours as well as others, sleep really matters for mental health while inpatient post-discharge, but we also believe and we have the hypothesis that good sleep while inpatient could be life-saving, and life-saving post-discharge, really. So we have a few papers where we outline kind of some issues with this and a model that we've developed, and outline the problem of Q15 checks. So ultimately, they're very well-intentioned protocols of these in-person checks to prevent self-harm, to prevent suicide within the hospital. However, there's a lot of unchecked windows of time. So somebody goes in your room, at the first Q15 check, then you have an unchecked window of 15 minutes, and then another one. And then another one. But the most common way to die by suicide inpatient is by asphyxiation or hanging. And you can do that in about 4 to 6 minutes. So we've developed this model, which now I wish we called something else because it's a tongue twister, but safety sleep suicide spiral, where we have the hypothesis is there's actually a compounding effect of sleep problems and sleep disruption based off of these checks. And so we are likely exacerbating the problem we're trying to prevent, particularly in certain populations admitted inpatient. And could we reverse that with alternative solutions? And one that we've thought a lot about is wearable-based monitoring. So if you think about it, if you're sleeping over 8-hour periods, so these are data actually from our inpatients, and show the average number of safety checks per night across a 6-week length of stay. And I believe it's in about 20 patients. And so on average, it's 36 checks a night. So when you fall asleep tonight, think about a stranger coming in your room every 36 times. Yeah, it's creepy. It's creepy, but also would disrupt your sleep, right? There's light that comes in your room, there's a sound, there's a clipboard, there's a door. These are anti-ligature kind of doors, so that sometimes they are really difficult to open or they slam shut behind somebody. So there's a lot of light, there's a lot of sound, there's also a stranger coming in your room all this time. And sometimes that stranger changes because the shift might change too, or just the people who are doing the rounding checks. So we pulled all this data. We've developed different Python scripts and stuff to systematically analyze digitized Q15 check data. We've also lined up our actigraphy data with this Q15 check data, and we find that about 73% of nighttime awakenings from the actigraphy data are associated, we consider them associated with a safety check. So the majority, and that's what patients report as well, that they wake up. So, all of these people that I have the pictures of, they're all our research assistants and amazing research staff that have generated these papers. This is one that describes the potential use of wearable technology to really improve this. And it's through a wearable-derived vital sign, kind of like telemetry, but for this use case of digital Q15 checks. And if you're interested in technology implementation, particularly for inpatient, please check out this paper. It was led by Jessa Westheimer, who has a background in neuroscience as well as art, and she has an amazing way to conceptualize technology and technology use, especially for inpatient. And so she has this outstanding model that she developed and really cross-referenced a bunch of different models in software design and user-based, human-centered design, and just really did a phenomenal job to outline a model that has in parallel process the development of technology with the clinical protocol. It's not one before the other, and really integration of empathy research to better understand and iterate the technology based off of the data. And so ultimately, at the end, the goal is that you have something that is usable and has inherent buy-in because you have involved all stakeholders and you have truly gotten all of the information in order to best understand the problem. So our goal is to really change kind of our model of suicide risk, particularly within inpatient, moving from assess, intervene, and monitor to assess, monitor, and intervene. And we've worked really hard to understand the wearables and what's out there in terms of wearables. And we've actually, so our first kind of iteration of our software, we use the Fitbit Sense. And since then, we've had to change because Fitbit was acquired by Google or somebody. They have locked it down. So we have changed to another wearable. But really thought through a competitive audit process for systematically evaluating wearables and all of the different variables and components of using a wearable for both research and clinical purposes, particularly in inpatient, because inpatient, you're also going to have safety issues with devices. So it's not only battery, it's not the technology, but it's also like, can you swallow something? Could you hurt yourself with the device in some way? So, and then we've developed the software. This is a old dashboard, but it's a good one because it's, I don't know if you all can see it. Peter loves The Office, so it's all Office characters. And we have really thought through how to, and worked with stakeholders to best understand how to leverage this data and visualize the data. The first time we ever discussed this with stakeholders, we thought, oh, if you're familiar with the BioPack and the Acknowledge software, you have data streaming and you see ECG signal and all the data are going across the screen. Oh yeah, we'll just design something like that with some alerts. And mental health clinicians or psych technicians, nurses were like, absolutely not. Do not give us that level of information. We don't want it. We won't know what to do with it. You have to train people a ton on it. We were like, right, that makes sense. Okay, and so they were like, instead, you have all the data streaming in real time in the background, and you actually tell people on the front end in the visualization exactly what to do. What is the clinical action that needs to be taken? Obviously, that has to be validated, which we've worked really hard to also do, but you tell the action that needs to be taken based off of that data. We also kind of have a decision, we kind of have a split in our data. The data goes to a visualization in real time, but that is also stored for research purposes and can be mined later as well. But throughout this, it's been incredibly important to have our stakeholders involved. So we have followed Jessa's model and very much have had a co-development process with nursing staff, with people with lived experience. And our goal, and we've done simulations of different cases. So our goal is that I can just hand this to anyone, and it's an intuitive software. So I could just, hand it to Justin, and I can give him the problem. Okay, go, do a safety check on Dwight, and he's in this room, and you can do that with zero error, with zero training. And I think that should be the end goal especially for inpatient, where the burden is so high, you have so few staff, there's high turnover. You have to develop technology that is intuitive. So with that, thanks, and I'll take questions, or maybe we want to go into the panel. I know we're out of time. Yeah.
Excellent. Thank you so much. Well, I'm sure people probably have questions, but I know we have another keynote starting in about 5 minutes. So maybe find Michelle and the other presenters if you want to continue the conversation. So let's thank everybody for their really interesting presentations today.